Good evening, and thank you to Alberto for kind invitation to speak in a so prestigious congress. So, to answer to question about my presentation, can viscosupplementation delay arthroplasty? I think that we have to answer to three kind of questions. First one, which joint we have to treat by viscosupplementation to obtain a delay in surgery? Second one, which kind of hyaluronic acid we have to use to have the better response? And finally, which kind of osteoarthritis can we treat by viscosupplementation to delay surgery? About the first question, the largest part of data available in literature are about knee osteoarthritis. The first paper in 2007 from Waddell collected 1,187 patients affected by knee osteoarthritis. Every patient had the fourth grade according to Kellgren-Lawrence radiographic classification, and all patients were treated with repeated courses of intra-articular treatment with Elan GF20, an high molecular weight product. And authors found very good results. After 3.8 years, the 75% of patients did not undergo to total knee replacement. And as you can see before, in 2016, Waddell published another paper with a larger cohort of patients on 1,863 patients, and he found that after 7 years of treatment, 75% of patients treated with repeated courses of intra-articular therapy with Elan GF20 still maintained the joint without surgery. And we have seen also the retrospective evaluation by Altman from the EMS Health Thermometrics Plus database. 79 million of patients selected, 182,000 patients who underwent to surgery, divided in patients treated or not treated by viscosupplementation, and authors found that without viscosupplementation, the main period of delay to surgery was 0.3 years. After one single course of intra-articular treatment, the period of delay was 1 year, and after 5 or more courses of intra-articular treatment, the mean survival time was 3.6 years. The same conclusion were founded also by Maheu and other European colleagues, and they found that the best responders to intra-articular treatment with hyaluronic acid are the patients without moderate radiographic score, second and third Kellgren-Lawrence degree, not too old, and with a high level of symptoms, because the high symptomatic osteoarthritis start the treatment before, and so can obtain better results. Another retrospective evaluation by a European group that selected data from 2 big European databases, selected 14,000 patients affected by knee osteoarthritis, found that yes, after viscosupplementation, we have a better results as compared to patients not treated by viscosupplementation. But not only. The number of courses and the duration of treatment is positively related to the improvement of the duration of the period of delay of surgery. And the other important point is that people who underwent to surgery after viscosupplementation or not had the same medical costs. So in other words, viscosupplementation can delay total knee replacement without increase costs for the health system. And the good predictors of response in this retrospective evaluation were also the recent diagnosis, the younger age, and the number of specialist visit, such as the treat to target for rheumatoid arthritis. We have shown the data about the paper from Professor Daza, and few days ago, Altman and Ong published this controversial paper from the Optum Climoformatics dataset in which they studied 4 million patients affected by knee osteoarthritis. We have to remark that only 27% of these patients were treated with viscosupplementation, and the positive effects was lower as compared to other paper I showed you before, with a mean survival time of 7 months and a trend toward the longer time of knee arthroplasty with repeated courses of hyaluronic acid injection. Other joints, we have few data about other joints in terms of delay of total joint replacement. A few years ago, our group published the orthobrick study about hip osteoarthritis. We retrospectively evaluated 185 patients affected by second or third Kellgren-Lawrence hip osteoarthritis. They were injected every 6 months under ultrasound guidance with 2 vials of Hyalubrix, and we found that after 48 months, the 82% of patients still maintained the joint without surgery. Second question, have we any evidence of superiority of a kind of hyaluronic acid as compared to other kind of hyaluronic acid to delay surgery? We have smaller data about the efficacy of low molecular weight products, but in these small cohorts, such as this one published in 2009, we found the same good results with, in this case, main survival times of 42 months before surgery. And the only comparative paper published in 2016, an observational cohort study using LifeLink Plus claims, who compared low molecular weight products, medium molecular weight products, and high molecular weight products, did not find any differences in the time to delay of surgery. But the most important, relevant point, in my opinion, is which kind of osteoarthritis we want to treat by viscosupplementation. We know that osteoarthritis have a pathophysiology very complex, involving cartilage, subchondral bone, muscle, ligaments, and capsule. And we know that differences in phenotypes is one of the more important points to understand some conflicting data in literature about not only intraarticular treatment, but any kind of systemic treatment for osteoarthritis. And we know that the scenario is more complex, but we have at least 2 kinds of phenotypes. The sclerotic one, 70% of patients, the osteoporotic one. In the first one, the activating by Wundt signal of osteoblasts induce the bone formation. This is a form usually slow progressive, not so painful. Sometimes can be inflammation and synovitis, but not so frequent. And this is a good target for the viscosupplementation. On the other hand, we have the osteoporotic form with an activation by the rank ligand and some cytokines of osteoclasts, a very high turnover in subchondral bone, and the presence of the bone marrow lesion. This is a very painful form of osteoarthritis, as this is not a good target for viscosupplementation, such as Professor Rahman said before. And I have to remark that at the moment, we have no data about any kind of treatment on selected population of people affected by osteoarthritis, not only for intraarticular therapy with hyaluronic acid, but for any kind of treatment. And so if we conclude with Professor Migliore and others colleagues that we are sure that viscosupplementation is effective to reduce pain and improve function in the treatment of knee osteoarthritis, because the effect size is good and the strong is the evidence. We have no the same we have no the same data about the delay in total knee replacement. And so we can conclude that with the available data, we have a possibility to delay the total knee replacement of 2 to 3 years after viscosupplementation, that no difference in period of delay of total knee replacement is demonstrated between different molecular weight products of hyaluronic acid, that the good target for viscosupplementation is the sclerotic form of osteoarthritis, but that we need of more studies to understand the predictors of response, to understand the best cyclicity and dosage to obtain a delay in total knee replacement, and what and how we have to change our approach in relation to different phenotype of osteoarthritis and different grade radiological of osteoarthritis. Thank you.